good discussion, guys. I just have 10 questions to review some orthopedics topics. So we'll just get started. So first question, 78-year-old female was walking down some icy stairs, slipped and fell down the stairs. Her vitals are normal. She's complaining of pain to her right hip. I know this is not a right hip, but where she hit the ground. And then what examination features of the right lower extremity would you expect to see if this is the X-ray? And it was the correct. So how many for A, B, C, D, E? All right, so good job. So this is a story of a femoral neck fracture, given the imaging. So the mechanism certainly could be a hip dislocation. So what would you guys see if you had a hip dislocation on exam? If you could see kind of so if we go back, I actually didn't make it answer, but you would see shortening, internal rotation, and adduction, whereas in this picture, we can see this is abducted, externally rotated and shortened. Right. So next question, 11-year-old male presents with right foot pain and difficulty bearing weight after slipping and turning his ankle while running. So on exam, there's swelling and tenderness at the base of the right fifth metatarsal, and your x-ray shows a proximal fifth metatarsal avulsion fracture at the base. So what's the best treatment for this patient? Give you guys a second to look through. And how many for A, B, C, and D. All right, so this one I probably could have given you a picture. So this is actually, I just want to talk about a Pseudo-Jones fracture versus a Jones fracture. This is actually something I saw recently in PEDS that we had the chance to talk about. So I was trying to describe a Pseudo-Jones fracture. So the treatment for this, so this is a fifth metatarsal base avulsion fracture versus a transverse fracture. So the location is a little bit different between the Pseudo-Jones and the Jones, and your treatment's actually going to be different. So for a Pseudo-Jones fracture, you're actually just gonna put the, usually, I guess a kid or an adult in a bulky dressing or hard sole shoe and kind of have them follow up, and then weight bearing is tolerated. And so basically Jones fractures are an increased risk for malunion, and it's a little bit more distal to the proximal tuberosity and does not have articular involvement. And so Pseudo-Jones fracture is a little less serious. So. All right, 8-year-old female presents with left ankle pain and difficulty bearing weight after slipping and turning her ankle while running backwards. Her x-ray is shown here. What Salter-Harris classification is this fracture? There's arrows, so we get this one. So A, B, C, D. So this is D. I always think this is a good picture to review. So this is a type 4 Salter-Harris fracture. And so that means, so with like the mnemonic, this is through the growth plate. So it's all across the metaphysis, physis, and epiphysis. So these are kind of our 4s and 5s are prone to more limb length discrepancy. Those are also more often our surgical fractures. All right, 27-year-old is running when her right ankle twists outward and falls to the ground, is complaining of pain at the right ankle and has some difficulty bearing weight. When you take a look at the right ankle, the exam is fairly unremarkable, but she's having some difficulty bearing weight still. So what additional physical exam finding is most likely to lead you to a diagnosis? So A, B, C, and D. Right. So what I was getting at here is, I know we talked about in our discussion the synesmosis squeeze test. And so this is a test that's positive when pain is felt upon squeezing the fibula and tibia together, because we're really looking at that synesmosis in between those two bones. Another test you can do is this external rotation test. It's kind of on the other side. And so basically, if pains reproduce with manual external rotation of the foot and ankle relative to the tibia, you would consider that test positive. But you have to just make sure you stabilize the tibia when you're doing this test because you're worried about kind of another fracture potentially. All right. 25-year-old male is playing soccer when he collides with another player and hyperextends his right knee. On your exam, you note discoloration of the knee. What exam findings confirm your suspicion of the most probable nerve injury with this dislocation? All right, sorry, I don't know why I switched numbers. 1, 2, 3, 4. All right, good. So, oh God. Okay, good. Well, it's B, it's 2. It's foot drop and gait instability. So this is when we have a knee dislocation. We talked about some of the soft tissue injuries, and one of them is peroneal nerve injuries. And so I'm sure you guys remember, the deep peroneal nerve provides sensation to the first dorsal web space, and then also basically, and also allows dorsiflexion of the foot and extension of the toes. And so when you have injury of this nerve, which can happen in dislocation, you can end up with foot drop and gait instability. All right, 11-year-old male presents with hip pain that began several days ago. He doesn't recall any trauma and has not had any recent illnesses. Exam is notable for an obese, well-appearing child. He's afebrile with normal vitals. What is a feared complication if this condition is not repaired? And so A, B, C, and D. Okay. So this is kind of, so this is a kind of description of SCFE. So it can be acute or chronic. So acute accounts for only about 25% of cases. And it'll typically be in kind of your described obese child, 10 to 14 years old. Your diagnosis is going to rely on both AP pelvis and frog leg lateral views of the hip. And so chronic SIP can be kind of subtle. And so it can be missed on the AP pelvis alone, which is why you're going to get your frog leg view. And so this is just a picture of so basically when you draw this line, you're going to have, so you see on the side, you can see that it's kind of slipped because it's fallen below this line. Whereas here, it's above the line. And so it's a way for you guys, when you actually look at your x-rays on your own, to see the slipped. All right, and then 6-year-old male presents complaining of elbow pain after he fell when he was running with his right hand outstretched. He has point tenderness, range of motion is painful. His initial x-ray is negative for fracture, but you notice a sign on his x-ray that can point you towards the most likely diagnosis. So yes, is it A, B, C, D? So this is just the posterior fat pad sign, and it's an indication, especially in pediatrics, of a suprachondral fracture. And so if you don't see a fracture on your initial imaging and you have a high suspicion based on the mechanism in your exam, you should consider that especially if you see this posterior fat pad, that you consider that that still might be what's going on. We recently had a patient in peds where we didn't see a fracture. It was read as negative. They said there was no fat pad, a radiologist said there was no fat pad. Dr. Shaw was not convinced. We actually were able to do an ultrasound of the fat pads, which was really neat. I'd never seen before, and there was enlargement. We basically put a posterior splint on the child, had him follow up. He actually followed up. He ended up coming into the ED again, and then had a obvious suprachondral fracture, so that was kind of neat. And the other thing that you can see is an anterior sail sign that's kind of highlighted here. So things to look out for, even if you have a high suspicion for fracture. Great, 40-year-old male is participating in a company-sponsored flag football game, and here's a pop in his ankle as he changes direction quickly. He has immediate pain and difficulty walking. Squeezing of the calf does not produce plantar flexion. What's the treatment for this injury? A, B, C, D. Yep. So this is classic story of Achilles tendon rupture with the positive Thompson test that we talked about. So initial treatment, rest, elevation, compression, that's like an ice, and avoiding weight bearing. And so we talked about in our group that sometimes ortho will put on posterior splint for these patients and kind of that plantar flexion and to kind of allow it to heal in that way. Occasionally some patients will require some surgical repair of Achilles tendon, but this is usually a pretty classic story. And this is a quick test that you can do in the ED. All right, and then this is, so 32-year-old male presents after a mechanical fall with a grossly deformed ankle that is neurovascularly intact. What is the name of the fracture that we see here on his imaging? So A, B, C, D. Okay, so this is C, this is can't say this, Masonov fracture. So this is basically something that should be suspected with injuries to the medial posterior malleolus or deep deltoid ligament without an associated distal fibular fracture. And so this is something you can actually, when you're performing a synesmosis squeeze test, you can probably detect the instability that's caused by this type of fracture. And so this is one of the reasons that we want to do, if we have some high suspicion for a fracture in the ankle, that we want to get those tib-fib films as well. And so these injuries typically will require operative intervention for enduring stabilization. And so, but that synesmosis squeeze test is kind of a quick way to say maybe something's kind of going on up there versus just in the ankle. All right, and so my last question. So we have a 19-year-old male presents with inability to bear weight with pain in the middle of his foot. He was in an MVC where he was the driver and had his foot bend in the middle during the impact while he was braking. The affected limb is shown here. What kind of fracture are you most concerned about? So A Jones fracture, B, a Lisfronk fracture, C, DeVerney fracture, D, Seagund fracture. So only two of those were even in the foot. So this one is a Lisfronk fracture. And so this is basically, so this is the Lisfronk joint complex. And so it's basically the articulation of the first, second, and third metatarsals with the kind of concomitant cuneiform, so medial, intermediate, and lateral. And it also includes articulation of the fourth and fifth metatarsals with the cuboid. And so basically this Lisfronk ligament secures the second metatarsal to the medial cuneiform and kind of anchors that entire complex. And so this type of fracture, the classic mechanism is when an axial load is applied to like a plantar flexed foot. And so when, so like a high mechanism is like in an MVC where a foot is on a brake and then the foot is kind of basically bent in the middle. And so the initial one thing to kind of know about this is that X-ray findings can be really subtle in the beginning. So normal foot X-rays don't actually rule out a Lisfronk injury if you have a high suspicion. You want to get weight-bearing views or CT if you have a high suspicion for this diagnosis. I also read about this piano key test. So if you kind of see this pattern, exacerbation of pain with dorsal and plantar flexion of each digit can kind of point towards this type of injury. And that's all I have.